an anticoagulant, and the patient faces one of two immediate outcomes. They either bleed out or throw a fatal clot. It's a high-stakes decision, yet medical textbooks bury the answers under pages of overlapping indications. That leaves junior clinicians freezing up at the bedside, unsure of which path to take. To fix this, we need to look at the three main drug classes actually available to you: the old standard, warfarin, the heparins, which include enoxaparin and unfractionated heparin, and the newer non-vitamin K oral anticoagulants, or NOACs. Selecting the right drug comes down to scenario matching based on the patient's organ function, prioritizing physiology over the age of the medication. Before we build that selection system, we need to clear the field. We are taking aspirin and clopidogrel completely out of this core discussion. These are antiplatelets. They serve a strictly preventative role, meaning they offer absolutely zero therapeutic value when you are trying to treat an active thrombosis. With those set aside, we can map the actual anticoagulants onto this blank three-branch decision tree. This framework is built to make the correct therapeutic choice obvious in under 60 seconds. By abandoning dense textbook layouts for this algorithmic flowchart, you reduce your cognitive load and prevent catastrophic ward errors during high-stress admissions. The first major patient category you will encounter is anyone presenting with valvular heart disease. Look at the first branch. The clinical rule is absolute. Valvular disease mandates the older oral option, warfarin. Expanding this node reveals its trade-off. Warfarin is incredibly slow-acting, taking 5 days to reach therapeutic efficacy, leaving a massive preventative gap. You cannot leave a patient unprotected for 5 days. To fix this, we use a clinical workaround called bridging. We fill that dangerous gap by co-administering enoxaparin, a low molecular weight heparin, for the first 5 days, protecting the patient until warfarin takes over. For valvular patients, you sacrifice the convenience of a fast-acting pill for precise control, accepting the heavy clinical burden of managing that inpatient bridge. Our second branch covers high-risk hospital admissions, specifically patients with active cancer or those who are pregnant. These patients require enoxaparin or unfractionated heparin. These IV or subcutaneous options ensure strict, rapid response control while they are admitted. Within these hospital admissions, there is a critical subcategory you must isolate: patients suffering from severe renal failure. The mnemonic UFH equals urine failure serves as a quick reference. When the kidneys are failing, unfractionated heparin is the mandatory choice. The reasoning is purely physiological. Most drugs are cleared by the kidneys, and if the kidneys fail, those drugs accumulate to dangerous levels. UFH bypasses that clearance problem entirely. You also rely on UFH for cases demanding rapid on and off reversal, like a massive pulmonary embolus or a patient heading straight into emergency cardiac surgery. The heparin class demands high maintenance through IV or subcutaneous access, but it buys you the granular, minute-by-minute control required for unstable or organ-compromised patients. That brings us to our final branch: stable embolic situations. This includes cases like a routine deep vein thrombosis or a stable pulmonary embolus. On this third branch, the rule is prescribing newer non-vitamin K oral anticoagulants, or NOACs, like apixaban. Highlighting this node reveals their massive benefit: rapid action. Contrasting directly with the warfarin branch shows you eliminate the complex 5-day bridge entirely. But that convenience has a strict limitation. NOACs are completely contraindicated for the complex valvular or severe renal cases we just covered. NOACs are a highly effective modern tool, provided you rigorously restrict their use to structurally sound, physiologically stable patients. Even with perfect selection, plan for worst-case scenarios. If severe bleeding occurs and blood pressure drops rapidly, you need an immediate reversal agent. This matrix maps out your specific safety nets. For warfarin toxicity, you administer vitamin K. Note the operational caveat here: vitamin K works, but it is a slow-acting antidote. Dropping to the second row, if dealing with heparin toxicity, you must administer protamine. Finally, reversing the antiplatelets aspirin and clopidogrel requires a physical platelet transfusion. Memorizing these specific pairings forms your ultimate safety net, ensuring you are never caught without a strategy when a therapeutic dose turns toxic. Let's pull the clinical framework together into a unified view. Rule 1: valvular disease mandates warfarin with a 5-day enoxaparin bridge. Rule 2: failing kidneys or rapid reversal mandates unfractionated heparin. Associate urine failure with UFH. Rule 3: stable embolic events get NOACs. Mastering this algorithm replaces pharmacological confusion with a definitive bedside protocol, helping you standardize care and mitigate risk in high-pressure environments.
Wait, you guys, we did it! It's our last sketchy farm unit. You know, it seems like only yesterday we were taking a stroll through that autonomic section. You remember that sketch with the antiemetic stadium? A preppy ant. I mean, that's just a good mnemonic. Oh, and do you remember the creepy Edgar Allan Poe one? I have no idea what was going on there, but for some reason, I was eerily aroused. Anyway, I hate to say it, but we're about to wrap up Sketchy Farm, and our grand finale? Cancer chemotherapeutic agents. Cancer can be treated regionally through surgical removal or targeted radiotherapy. Chemotherapy, on the other hand, involves the systemic administration of cytotoxic drugs to eradicate or control the proliferation of cancer cells. However, their dispersal throughout the bloodstream means that these drugs reach both cancerous and normal cells alike, leading to significant systemic adverse effects. Compared to slowly dividing cells, however, rapidly proliferating cells like cancer cells synthesize larger amounts of DNA and RNA per unit time. The pathways involved in de novo nucleotide synthesis therefore have become attractive targets for the control of rapidly dividing cells. And when I say attractive targets, I mean ridiculously attractive, like Idris Elba attractive. This entire chapter focuses on antimetabolites, molecules that exert their anti-proliferative effect by mimicking the intermediates involved in various steps of nucleic acid metabolism. They can masquerade as a purine or pyrimidine, for example, the nitrogenous bases that form the backbone of DNA. This tricks a tumor cell into incorporating these molecules into DNA, leading to strand breaks. Or these drugs work by replacing other key intermediate molecules necessary for the production of new bases, like a folate analog, for example. This clogs up the enzymatic machinery responsible for DNA synthesis, and cell growth is halted. In this sketch, we're going to focus on anti-metabolite drugs that inhibit the enzymatic pathways involved in the formation of thymidine specifically, with special attention paid to agents that affect the folic acid cycle, but we'll get into that in a bit. Thymidine is a pyrimidine deoxynucleotide. Deoxynucleoside just means that it has one of those deoxyribose pentose sugars attached. I know, who cares, right? It's the pyrimidine nitrogenous base we're going to emphasize here. At Sketchy, we depict pyrimidine and purine bases by their molecular structure. Just think back to the acyclovir airport or the ganciclovir market. Purines such as adenine and guanine are represented by a hexagonal shape attached to a pentagon. Ganciclovir is a guanosine analog, remember, as depicted by these ganciclovir cans. Pyrimidines, on the other hand, such as thymine, cytosine, and uracil, are depicted by their lone hexagonal structure, like this hexagon plate here on the sushi bar counter. The synthesis of thymidine is catalyzed by thymidylate synthetase. You know, because it synthesizes thymidine? I mean, that's just a good name. You know what I call gloves? Hand socks. Anyway, this enzyme works by methylating a phosphorylated uridine called deoxyuridine monophosphate, or DUMP, and turning it into a phosphorylated thymidine called deoxythymidine monophosphate, or DTMP. Think of it this way. See that hexagonal plate of dumplings? It's hexagonal because it depicts a pyrimidine precursor molecule, and the dumplings are meant to represent DUMP specifically. Once a customer chows down on those DUMP dumplings, it's converted into DTMP, as you can see here. You've got one dumpling left for the D, and then a pair of chopsticks are set down on the plate, evoking the thymidine T. This whole reaction, turning DUMP to DTMP, is powered by the folate cycle, represented here by the cycle of sushi boats going by. Uridine is methylated to turn into thymidine, so it just needs a carbon, right? Take a look at that incoming boat on the left. It turns out that a methylated tetrahydrofolate provides that carbon. At Sketchy, we represent folate with foliage. So in this scene, tetrahydrofolate is represented by a boat with 4 leaves, probably some Mizuna or something. And that C-shaped sushi represents the carbon available for donation. As the boat floats by, the customer dining on those DUMP dumplings transfers over that carbon sushi to his plate, inadvertently knocking off 2 of the folate leaves as well. Thus, tetrahydrofolate is converted to dihydrofolate and DUMP is methylated to DTMP. This whole process catalyzed by thymidylate synthase. In order to keep producing more thymidine deoxynucleotides, you need to recycle that folate so it can donate more carbons. In other words, you've got to turn that dihydrofolate back into tetrahydrofolate, and here's how that happens. Stay with me here. Dihydrofolate, represented by the boat with 2 leaves, gets converted back to tetrahydrofolate by the enzyme dihydrofolate reductase. It's a reductase because you're adding 2 hydrogens, so you're reducing it. Notice that tetrahydrofolate is again represented by the boat with 4 folate leaves. Well, tetrahydrofolate is a carbon donor, so let's get that carbon back on it. A methyl group contains a single carbon, so tetrahydrofolate is then methylated, represented by the addition of the C-shaped carbon sushi. Tetrahydrofolate is now ready to donate some more carbons and methylate those deoxyuridine dumplings into some brand new pyrimidine nucleosides. That is, unless you throw our first antimetabolite agent into the mix, methotrexate. Methotrexate is a folate analog, so it looks like folate, but it's not. It competitively and irreversibly binds to dihydrofolate reductase, preventing the conversion of dihydrofolate into tetrahydrofolate. Think of methotrexate as this methotrexate meat stick chef. He's trying to replace folate like a folate analog, if you will. Instead, he's irreversibly upended that sushi boat and brings the folate cycle to a halt. With dihydrofolate reductase irreversibly inhibited, targeted cells can no longer regenerate tetrahydrofolate, and as you can imagine, the precursors folate and dihydrofolate will build up inside the cell like this traffic jam of dihydrofolate sushi boats. No tetrahydrofolate means no de novo synthesis of that thymidine nucleoside DTMP we keep talking about. And that's not all, because tetrahydrofolate is also involved in the synthesis of purine nucleosides and some amino acids as well. Inhibition of these metabolic pathways interferes with the formation of DNA, RNA, and key cellular proteins inside rapidly dividing cells. Dividing is the key here. Rapidly proliferating cells, such as cancer cells and inflammatory cells, are preferentially inhibited by methotrexate because it's these cells that are producing substantially greater quantities of nucleotides. So, since we're targeting DNA synthesis specifically, antimetabolites like methotrexate and the rest of the agents in this chapter are most effective during the S phase of the cell cycle, the stage when cells are undergoing synthesis of new DNA in preparation for cell division. In fact, many of the anti-cancer drugs in this unit exert their action on cells traversing a specific phase of the cell cycle and are therefore called cell cycle specific. Whenever an anti-proliferative agent is cell cycle specific, we'll be sure to depict that particular stage within the sketch, like in the name of this sushi restaurant here, sushi phase. Also, because these agents prevent the synthesis of DNA, their logo depicts a pair of chopsticks clamping down on that growing strand of DNA-evoking ramen noodles. This is how methotrexate acts as a chemotherapeutic agent. It's a folate analog that halts DNA synthesis in rapidly dividing cells, leading to cell death. It's cytotoxic. I mean, just take a look at this broken cancer crab here, our recurring sketchy symbol for agents with anti-neoplastic effect. Methotrexate can be used in combination with other chemotherapeutic agents to treat a range of malignant conditions, especially leukemias, lymphomas, as well as solid tumors such as breast cancer, head and neck cancer, and lung cancer. Also, because methotrexate causes death of all rapidly dividing cells, it can be used to treat a wide variety of non-neoplastic conditions that are characterized by abnormal cellular proliferation. Just take a look behind our methotrexate chef, where a couple of customers are emptying their backpacks and making off with a few more of those methotrexate meat sticks. I mean, it did say all you can eat. Though, I don't know how well those are gonna save. They should probably wrap those in like a napkin or something. Anyway, take a close look at that overturned backpack and you'll notice that it looks somewhat uterus-like. Methotrexate can be used for the termination of intrauterine pregnancy in conjunction with misoprostol. It inhibits trophoblast cellular division, thus decreasing trophoblast survival, hindering implantation, and encouraging expulsion. Methotrexate is also the drug of choice for the non-surgical treatment of an early, unruptured ectopic pregnancy. That's because folate antagonists are effective in hindering the growth of rapidly proliferating cells in developing embryos. See that little baby keychain clinging onto the outside of that uterus? It's just like an ectopically implanted embryo. Aberrant fertilization events can also lead to gestational trophoblastic neoplasias, including trophoblastic tumors, choriocarcinoma, and invasive molar pregnancy. Each arises because of an abnormal proliferation of trophoblastic tissue, and most low-risk patients can be cured with a short course of methotrexate chemotherapy. So as she makes room for those purloined methotrexate meat sticks, a little mole stuffed animal falls out of her backpack as well. Kind of like the termination of an invasive molar pregnancy, if you will, and you probably should. Just trust me on this one. You know, these sketchy medical videos reach a wider audience than you'd think, including droves of young preteen fans. I mean, we're like the teen idols to them. That's why they call me Jordan Knight. Oh, is that too outdated? Kirk Cameron? Anyway, we try to set a good example, and that's why we've added this totally rad protective equipment to these skater punks. Wait a minute, silvery scale on extensor surfaces? That can only mean one thing: psoriasis. Psoriasis is a common chronic skin disorder most commonly characterized by erythematous plaques with silver scale and hyperproliferation of the epidermis. So, proliferating cells, we can use methotrexate, right? Yes, and it's also effective for the treatment of psoriatic arthritis and psoriatic nail disease. Initially, the mechanism of action was thought to involve the antiproliferative effects of methotrexate on rapidly dividing epidermal cells, though more recent evidence supports the concept that it's actually the immunosuppressive effect of methotrexate that controls psoriasis. That's right, neoplastic cells aren't the only rapidly dividing cells targeted by this antifolate agent. Methotrexate also effectively inhibits the proliferation of immune cells and is therefore used to treat a wide range of chronic inflammatory conditions. You see that lantern we've sketched in above our methotrexate meat chef? The design should remind you of a joint. Not only that, the flame sitting inside should remind you of the inflammation associated with rheumatoid arthritis, or RA specifically. This symbol is actually going to show up throughout this unit whenever we want to highlight the immunomodulatory agents used in the long-term management of RA. The foundation of long-term therapy consists of disease-modifying anti-rheumatic drugs, or DMARDs, DMARDs, including methotrexate, sulfasalazine, hydroxychloroquine, and TNF-alpha inhibitors. These agents inhibit the proliferation of immune cells responsible for the chronic inflammation and long-term joint destruction that eventually leads to disability. On your exam, a typical clinical scenario will involve a middle-aged woman with swelling, pain, and morning stiffness in multiple joints for more than 6 months, as well as some other characteristic systemic symptoms. Methotrexate is the preferred first-line disease-modifying treatment for most patients with moderate to severe RA, though response to DMARD therapy typically takes weeks. Short-term treatment with anti-inflammatories like glucocorticoids or NSAIDs can provide temporary relief of symptoms, but they do not provide adequate long-term control of disease or prevention of joint deformity. For that, methotrexate is often your go-to agent. It doesn't stop there, though, because methotrexate's immunomodulatory effects are useful in the management of numerous other chronic inflammatory and autoimmune disorders such as IBD, lupus, vasculitis, and dermatomyositis. So we've included a few antibody-evoking lanterns as well, torn in order to highlight methotrexate's ability to suppress the immune system. All right, let's talk side effects. When methotrexate reaches the systemic circulation, it causes death of all rapidly dividing cells, leading to a characteristic set of adverse effects that you are more than likely to run into on your exam. First off, remember that methotrexate is a folate analog that directly binds to dihydrofolate reductase, inhibiting the body's ability to regenerate the active form of folate, tetrahydrofolate. This can lead to a state of folate deficiency as evidenced by that foliage that tumbles to the restaurant floor. And this can cause megaloblastic anemia, which is a form of macrocytic anemia in which nucleic acid metabolism is impaired, leading to reduced efficiency of cell division and nuclear cytoplasmic dyssynchrony. Our recurring symbol for megaloblastic anemia? A megablast of fireworks, of course. With higher doses of methotrexate, myelosuppression becomes the major dose-limiting side effect. This can manifest as pancytopenia, kind of like this bone-shaped pan of sushi getting dumped by our careless waiter here, evoking that bone marrow depletion. Peripheral complete blood counts should be monitored regularly in patients on long-term methotrexate therapy. Methotrexate can also cause pulmonary fibrosis. Notice that bonsai in the back there depicting a fibrotic, though meticulously cultivated pair of lungs. Pulmonary fibrosis presents with gradual onset dyspnea, first with exertion and then progressing to symptoms at rest. PFTs will show a restrictive pattern of lung involvement, kind of like the restricted growth of this bonsai. You'll see decreased lung volume, decreased FEV1 and FVC levels, a normal-ish FEV1 to FVC ratio, and a decreased diffusion capacity. If you're given a chest x-ray, you'll probably see bilateral diffuse patterns of small, irregular opacity, most pronounced in the lower lobes. Just think of those tiny scattered bonsai leaves. And microscopically, progressive fibrosis can lead to dilated bronchioles that later coalesce to form that classic honeycomb appearance found in advanced disease. Methotrexate can also cause hepatotoxicity as depicted by that greasy liver-shaped stain left behind after a long day of meat stick handling. Hepatotoxicity due to methotrexate probably results from direct damage to hepatocytes. Minor elevations in aminotransferases are common, but hepatic steatosis, fibrosis, and even cirrhosis could occur. LFTs should be monitored routinely in patients on long-term methotrexate therapy. We're not done yet because methotrexate is on a rampage, destroying every rapidly dividing cell in sight, hair follicles included, leading to alopecia. And mucosal cells too, leading to stomatitis or soreness of the mouth. Whoa, that's fresh off the grill, man. You can't just poke a meat stick in your mouth like that. You better check your mucosa before you wreck your mucosa, friend. Do you see that figurine in the back there? That's a maneki neko, literally meaning beckoning cat. It's a common Japanese figurine which is often believed to bring good luck to the owner. In this sketch, this lucky feline symbolizes leucovorin, a special reduced form of folate called folinic acid. Think felinic acid. Leucovorin is used to reverse the toxic effects of methotrexate, especially bone marrow, GI, and mucosal-related toxicity. This is called leucovorin rescue. You see, folinic acid does not require dihydrofolate reductase, the enzyme blocked by methotrexate. Furthermore, it displaces methotrexate from intracellular binding sites and restores active folate stores required for DNA and RNA synthesis. Folinic acid may also be useful for treatment of acute methotrexate overdose. Quite lucky indeed, little maneki neko. All right, let's... sorry. It's just so many dumplings, you know? I just gotta take a few chapters. Okay, I'm good. Where was I? Let's head back over to our man with the DUMP dumplings because I want to introduce you to the other antimetabolite drug that blocks the folate cycle, 5-fluorouracil or 5-FU. Oh, it looks like his friend is about to burst from eating one too many dumplings as he waves his hand at him. Because he's full and waving those 5 fingers, he's going to be our symbol for 5-FU. 5-FU is a pyrimidine analog, which is why he has that hexagonal pyrimidine-shaped plate in front of him. It primarily functions to inhibit DNA synthesis via inhibition of thymidylate synthase. Remember, thymidylate synthase catalyzes the conversion of DUMP to DTMP as represented by that plate of dumplings converted to the pyrimidine-shaped plate containing chopsticks arranged in a T. Remember, that's T for thymidine. This whole process is accomplished by transferring over a carbon donated from that methylated tetrahydrofolate boat floating by. as depicted by our dumpling connoisseur here grabbing that little carbon sushi roll from the boat. Tetrahydrofolate in turn is converted to dihydrofolate, a boat with 4 leaves entering and a boat with only 2 leaves leaving. Well, in the body, 5-FU is metabolized by a series of intracellular reactions to its active form, 5-fluorodeoxyuridine monophosphate, or FDUMP. F-dump. F-dump forms a complex with both thymidylate synthase, the enzyme responsible for that carbon transfer, and that tetrahydrofolate passing by. And that's why our overly full 5-FU patron is covalently grabbing onto those chopsticks about to donate that carbon sushi from the tetrahydrofolate sushi boat. This complex stops the de novo synthesis of thymidine, which inhibits DNA synthesis. DNA synthesis is occurring in S phase, of course, so remember that the agents in this sketch are cell cycle specific. I mean, this is the world-renowned sushi phase restaurant after all. Other active metabolites of 5-FU inhibit cellular function and division in other ways. By incorporating into RNA as 5-UTP, it interferes with RNA processing and mRNA translation. Or by incorporating into DNA as 5-DUTP, it interferes with DNA synthesis and function. However, for your exam, remember its effect here on the folate cycle, blocking that thymidylate synthase. As you can imagine, once thymidylate synthase is blocked, DUMP has nowhere to go and builds up in the cell. And it looks like those extra orders of DUMP dumplings just keep coming, piling up behind our inhibited sushi transfer over here. Also, keep in mind that cracked cancer crab in the center of the sushi boats meant to remind you that all these drugs can be used in cancer chemotherapy. 5-FU specifically is the most widely used agent in the treatment of colorectal cancer. This agent also has activity against many other solid tumors, including cancers of the breast, head and neck, liver, pancreas, and even topically for basal cell carcinoma. Now, most chemotherapeutic agents are associated with acute GI toxicity like nausea, vomiting, and diarrhea. Certain agents, though, such as irinotecan and 5-FU, cause major cytotoxic damage to all those rapidly dividing cells of the intestinal mucosa, leading to loss of epithelium and severe diarrhea. I mean, just take a look here at our full 5-FU patron struggling to hold down his dumplings. Did he sit in something? Maybe ponzu? I sure hope that's ponzu. A variety of cutaneous complications can accompany the use of therapeutic agents such as methotrexate and 5-FU. This includes photosensitivity reactions, and what an opportune moment to take some sensitive flash photos. Remember that 5-FU is associated with a variety of other rashes and even hyperpigmentation reactions. By depleting thymidine and inhibiting DNA synthesis, 5-FU can also cause myelosuppression and an increased risk of infection. So don't forget about our myelosuppressed server in the corner, complete with that recurring immunosuppressed cane. Although that lucky feline, folinic acid, can be given with methotrexate to rescue the bone marrow and prevent toxicity to the GI tract and other mucosal cells, this is not the case with 5-FU therapy. Even with a fresh supply of tetrahydrofolate around, if thymidylate synthase is inhibited, you just won't be able to turn that DUMP into DTMP no matter how hard you try. I mean, just look at that guy. So, as our full patron here backs away from the dumplings and succumbs to toxicity, he knocks one of the lucky felines onto the ground. Not so lucky this time, little Maneki-Neko. Alright, there is one more drug that I want to mention that affects the thymidine synthesis pathway. I know, you're full, that guy's about to black out, and I'm barely able to contain my stomach contents right now, so let's take a few steps back from the DUMP dumplings. Remember that thymidine is a deoxynucleoside found only in DNA, not RNA. But the thing is, it's actually ribonucleotides that are synthesized first and then converted to deoxyribonucleotides used in DNA. So, the precursor to all those pyrimidine nucleotides is, in fact, a uridine monophosphate, or UMP, which is subsequently phosphorylated to uridine diphosphate, or UDP. UDP is represented here by the sign at the entrance, "You dining in? Please sign in." UDP, it turns out, is the substrate for ribonucleotide reductase, which converts UDP to deoxy-UDP, a molecule that will eventually go on to form all those deoxypyrimidine nucleosides we need for DNA synthesis. And it looks like someone has signed in. Oxy, party of one? As the waitress crosses off the name oxy and reduces the length of the list, think of ribonucleotide reductase, converting that UDP into its deoxy form. Now we're getting somewhere. Once we have DUDP, we can dephosphorylate it into those DUMP dumplings. And since the wait times at Sushi Phase can be, well, as the last Yelp reviewer put it, excruciating, why not enjoy the peaceful Zen garden fountain in the corner while you wait? A hydro rock area, if you will. The name hydro rock area should remind you of hydroxyurea, the chemotherapeutic agent that blocks ribonucleotide reductase. Notice how this mom here knocks over the ribonucleotide reductase waitress as she rushes over to get her kids out of that hydro rock area. Inhibited ribonucleotide reductase prevents the de novo synthesis of thymidine, which means DNA synthesis will be inhibited. This arrests the cell in the S phase of the cell cycle. That's S for Sushi Phase. As an anti-cancer therapy, hydroxyurea can be used to treat acute and chronic myelogenous leukemia, so remember too,